Praful was my immediate senior. Means, in fact, we were from the same batch.
We were colleagues. I was not senior.
વેનસો નાખતા પ્રફુલે શીખવાડ્યું છે અને અમારા બધાના કોલ પ્રફુલ એટેન્ડ કરી લેતો હતો. એટલે અમારે આમ તેમ જો રખડવા જવું હોય તો પ્રફુલ વોઝ અવર હેલ્પલાઇન. So I am happy that I have a chairperson with whom I spent my 3 years of residency. And let me thank the organizers for not just giving me this opportunity, but also giving me the best panel. Because when this panel is there, I don't have to worry, because I will not have to answer any question. They all are experts in their field. And so at the end of the session, you will agree with my statement that I am lucky that I have been given this panel. And one more reason, that Dr. Sangeeta ma'am and Dr. Surendranath sir, we worked together in 2019 Central IIPB when I was the national president. So again, I have a, જે કહીએ ને આજે કે એક મેળાવડા જેવું છે. Initially the college time મેળાવડો, and Charul is also my BJ8 alumni. So it's like a get together for all of us. So anyway, we have 40 minutes as per the time allotted by the organizers. What I have done, that we will try to cover 4 vaccines in 35 minutes time, and we will keep 5 minutes reserved for your questions from the floor. What I request, that if you have any queries related to these 4 vaccines, you can write down your questions and send it to me, because some of the questions might be addressed by the experts during the initial discussion. Also, to have a more discussion on particular vaccines in a short time, what we have done, that initial phase we will be having 2 or 3 questions related to each vaccine, and in the later part there will be a rapid fire. And this rapid fire, we will try to extract more information from our experts, so that in 35 minutes time we can cover the subject better. So my team is already introduced by our chairperson, so I won't again reintroduce them. And we all know that vaccine science is changing very fast. It is very dynamic, and with the position, with the change in the epidemiology, the recommendations are also changing. With the change, like just now Praful told about that JE. Earlier we used to believe that this is a illness which is predominantly in certain states, but now it is almost all across our country. So when there is a change in epidemiology, the people who are residing in the area where the disease was not prevalent, they also need to know about that particular vaccine. And many times it may not be 2 plus 2 is equal to 4. So that is why immunization dialogues are always session of interest for most of the delegates. So with this brief preamble about the subject, as the organizers have allotted us, we will discuss hepatitis A vaccine, Rota vaccine, meningococcal conjugate vaccine, and Japanese encephalitis vaccine. So first is hepatitis A vaccine. Sangeeta ma'am, what is the significance of epidemiology in context of hepatitis? Because many times people used to say, I remember people used to say કે આપણા countryમાં તો બધાને by the age of 4 years, 5 years jaundice થવાનો જ છે. So earlier days we used to say કે ભાઈ hepatitis A vaccine is not for a country like India. But now with the current status, what is your stand, whether these recommendations of hepatitis A is relevant or still we need to modify it?
Thank you very much, Dr. Digant, for that lovely introduction. And we all are part of the team. Together we have been And I thank the organizers for having organized this wonderful academic event, and which has been a great success. As far as epidemiology of hepatitis A is concerned, I have gone through these last 2-3 decades, and hepatitis A epidemiology has changed because what has happened is that we have moved from high risk to the intermediate endemicity. Now, what do we mean by high, from moving into intermediate endemicity? Because earlier the children used to get, younger children used to get exposed, and by the time they would be in their mid childhood, they would, most of them would be having antibodies to the tune of 90%. But of late, it has been realized that this disease has now shifted its pattern towards the adolescents and the young adults, and the incidence, according to the various systemic review, which is last available of 21, which has said that now the incidence between 5 to 15 years, to be more precise, is 2 to 55%. And we all know that WHO has the elimination target for viral hepatitis for 2030. So therefore, we need to have targeted immunization for this risk group, especially the adolescents, the young adults, the ones who are coming from higher socioeconomic class. And we all know our food culture pattern has changed. Now we order food, we
Swiggy
love
and
to,
Zomato are very popular, as
and
well
we
as
eat out, and so
street foods.
therefore, exactly. And I have seen quite a few in my clinical practice of late. Even last week, I had this young girl who had gone into, who was hepatitis A positive. She had gone into stage 1 hepatic failure, 4,000 enzymes with her
Right.
serum ammonia of 105. So at least I was there. I picked it up. She was transferred to ICU.
So
and
I
then she
think
went
Madam has
home
very
happily.
well pointed out all the factors that there is a definite change in the epidemiology. I remember one statement by our vaccine Shah, Nitin Shah. In older days, it was one of the gathering, maybe 20 years back when we were discussing. He said that this is a vaccine for people who are having mobile in one hand and Bisleri bottle in another hand, for that class of people. But nowadays, mobile Geo, with grace of Geo mobile, everyone is having water bottle. Now everyone is drinking the Bisleri water or RO water. But still the epidemiology has changed, and there is a one study which was conducted, multi-centric study, in 4 or 5 cities like Indore, Patna, Calcutta, Cochin, Jaipur, and they found that the seroprevalence rate in the age group is going low. And so when the seroprevalence is going low, that means that that child is at risk of getting the hepatitis A infection. And if you don't provide the protection to that child with the vaccine, which is safe and effective, I think you are doing a crime. So definitely the recommendations are what you call most justified. Now, Dr. Surendra sir, the question is that what is our current recommendations regarding hepatitis A vaccine? There are two vaccines available, the inactivated vaccine and live vaccine. Still, though there are many data about the live vaccine, but still people are confused about should they use the live vaccine, is it safe, Chinese vaccine, is it safe? So, and what should be the number of doses, how frequently? So can you just elaborate on about the products and the route of administration, number of doses?
Thank you, sir. Before going to the different types of, I just wanted to add one more thing in the epidemiology.
Yes.
If any child gets infection during the infancy, less than 2 years, the manifestations are minimal and the morbidity, mortality is very less. It is asymptomatic infection most of the times.
Yes.
So previously when we had a unhygienic conditions where we used to drink the water anywhere, almost by 2 years, 90% of people used
They
to be
used to
seropositive.
develop
But fortunately, there is increase in the
hygiene and
good
yes.
water supply. Now they are not getting infection during the infancy. Now the infection is getting to the adolescents where the risk rate is high, mortality is high. and morbidity is high.
Absolutely.
So that is the reason that we should vaccinate these children. And not only that, we have certain outbreaks where the transmission is, we are in an intermediary zone. So if it is a high endemicity, there will be transmission at infancy. Intermediate risk, there is transmission in the adolescence. Whereas a low endemicity area, there is no transmission at all. But intermediate zone, there is still the transmission is there and the susceptible people are there. So that is the reason in this situation, we need this vaccine very well.
So definitely we all are on the one page about that there is a need for this vaccine. So now which vaccine, what route, how many doses,
we have
what
types,
age?
We have two types of vaccines as sir has told, inactivated vaccines and live attenuated vaccine. Live attenuated vaccine is an imported from the China. Recently, I mean, it has been recommended that only single dose of live attenuated vaccine after 1 year is enough. There is no need of any booster. Whereas the inactivated vaccines, there are almost 3 companies are there now.
Yeah.
Sir has listed
3,
2.
4, in fact.
Yeah.
Avrix, Avexim, and then you have
Vaccine.
Hepa Shield?
Hepaviv. So Avaxim, Havrix are available. Now we have Indian company is also manufacturing. 3 inactivated vaccines are there. They are recommended as a 2-dose schedule, 1 dose at 1 year of age, and you can repeat the dose of second dose after 6 calendar months after the first dose.
Absolutely.
So at 1.5 year we can give this dose. And there is slight difference between the 3 vaccines. The B vaccine is, it is also a Chinese vaccine, but an inactivated vaccine, which has been there in the China for a long time. But whatever it is, these vaccines have proven that incidence of the hepatitis A has come down. With a 1 dose of live attenuated vaccine, incidence has come down in China. Even with 1 dose of hepatitis A, Brazil has shown that even that is also very effective, even if as a single dose. But at present, recommendation is 2-dose recommendation for inactivated.
So we will discuss about the single dose, about the vaccine maybe in the later part. But about the live attenuated hepatitis A vaccine, there were initial phase, there were lot many doubts also, and because there were no long-term studies from our Indian origin, so we were taking the recommendation of the manufacturer with a pinch of salt. But now we have almost more than 15 years, 20, almost nearly 20 years, 2006 to 17 years data of this vaccine in various centers, and it has proved its efficacy. So single dose is sufficient, no need to doubt about the product. Dr. Tushar, we usually speak about the prevention is better than cure. So naturally we offer the vaccine before the person is exposed. But is there any role of hepatitis A in a post-exposure prophylaxis?
Yeah. So when there is a close contact or an immunosuppressed host or somebody where chronic liver disease patient, especially whenever there is a history of contact and you want to use it as a post-exposure prophylaxis, this vaccine can be very well used. So within 2 weeks of exposure, if the vaccine is given, it has a definite role. The only thing is that it is different for different age groups. So like say, suppose you are using it under between 1 year to 40 years, then either you use a live or an inactivated vaccine, either of the 2 vaccine in the recommended schedule, one can definitely use it. If you are using above 40 years of age, they say that only the vaccine may not be sufficient and you may need to use immunoglobulin. And the same holds true when you want to use as a post-exposure prophylaxis under 1 year of age, where a vaccine is not recommended. So you may use immunoglobulin.
Absolutely.
They say that when you use post-exposure prophylaxis, the efficacy based on some data that WHO had predicted is almost to the tune of 82 to 87% when it is rightfully used. So definitely it has a role and it can be used in given situation. So but when you are using it for immunocompromised host, you must remember that the live vaccine is contraindicated, where you need to use inactivated.
So that is a basic principle of immunization, that in a immunocompromised host, any live vaccine is contraindicated. But at the same time, in immunocompromised host, when you are giving the hepatitis A vaccine for as a post-exposure prophylaxis, along with that you have to give the immunoglobulin also. Similarly, if you are any person who is traveling from low endemic area to the endemic area, like a person from US coming to India, in that case, if there is a less time before traveling to offer the 2-dose schedule, in that case also the hepatitis A immunoglobulin with 1 dose of your vaccine is sufficient. And young children, as he said, less than 1 year, you cannot give the vaccine. So for them again, hepatitis A immunoglobulin is for the prophylaxis. So now with this brief discussion about hepatitis A, we move on to the next vaccine, that is the Rota vaccine. And sir, what are the vaccines which are available in our country? And though it is a little controversial answer question, which is the best among these?
We have right now, we have 4 companies having the vaccine.
Yes.
Sir. Out of the 4, 2 are monovalent vaccines and other are pentavalent vaccines. As far as the efficacy is concerned, there is no difference between monovalent and pentavalent vaccines. And the efficacy part in US and where developed countries, the Rotarix, Rotatec have shown almost 90% efficacy. But unfortunately, when it came to the developing countries, the efficacy rate has fallen down to around 50 to 60. So for a severe gastroenteritis prevention, all the vaccines are stand on the same around 50 to 60% efficacy. And if you take
for very severe, any data available about the very severe gastroenteritis infection? Because again, these 2 vaccines, the Rotarix and Rotatec, are not so far no studies done in India.
Yes.
We have only studies from Rotavac and Rotasil only, Serum and Bharat Biotech.
We have the efficacy data which is shown that Rotavac for very severe gastroenteritis, same written there almost 54%, and even Rotasil also. For very severe gastroenteritis, both are same, sir. For severe gastroenteritis, maybe the Rotavac scores little better than the Rotasil, because Rotasil for severe gastroenteritis is around 40%. So, but I think all the vaccines are equally efficacious in prevention of very severe gastroenteritis.
So I just put that second part of the question purposefully to get that comment from my expert that all 4 Rota vaccines which are available in our country are safe, effective, and rather than thinking about this is best or this is less better than other, I think we should offer whatever vaccine we have available, or as in the morning Chetan told about the commerce part, thinking the cost part also. So I think any of the, but we should definitely offer Rota vaccine to the children who come to us, because this is a one condition which we can prevent the mortality related to the very severe and severe gastroenteritis. Right. Dr. Bhaskar, so far you were silent. So now the question is to you about our ACVIP recommendations So these are the common, these we all know it, but we need to revise the recommendations. Rather than asking the uncommon questions, I thought that let me revise the audience with what are the recommendations. So what is our ACVIP current recommendations?
Sir, IAP ACVIP recommends that the first dose of all rotavirus vaccine should be given before 14 weeks of life, and the last third dose should be given before 8 months, that is 32 weeks. And as RV1 is 2 doses only, it should be given within the 6 weeks and 10 weeks. And other 3 vaccines can be given 6, 10 and 14 weeks. Slightly it is different from the government of India's recommendation.
So maybe that we will discuss afterwards. But as our ACVIP recommendations are in line with the WHO recommendation, and WHO recommends 3-dose schedule for vaccines other than Rotarix. For Rotarix, this is a 2-dose schedule, 6 and 10 weeks. For rest of the vaccine, again, our 2 vaccines, Rotasil and Rotavac, I think they are licensed only for use in India. So the WHO recommendations for other countries, maybe for the other vaccines, but for our country, in context of the 4 available vaccines, this is a recommended schedule of WHO as well as ACVIP. And so what Dr. Bhaskar was telling in that context, Sangeeta madam, what is the current UIP schedule about the Rota vaccine, and why there is a difference between ACVIP recommendations and the UIP schedule?
Number one is ACVIP, we do individual protection. We are one to one.
Yes.
As far as national immunization schedule is concerned, we are public health. So therefore, we have to cater to the masses, to the larger population.
Yes.
So therefore, we have a little difference, and we wanted so that most of our children who are actually
Absolutely.
more vulnerable in who are there in the conditions with less sanitation, with a poorer water supply. So therefore, they made they said that it can be given. Rotavirus vaccine can be given
Up to
up to the age of 1 year.
1 year.
And you can even give, you should give another repeat dose after say 4 to 8 weeks, and another one if there is second birthday, if you are giving, then you can give 2 more doses to them as per the schedule. So you can give almost 3 doses. And we all have that question mark in our mind related
About
to
the risk of interception.
interception.
And because see, we all as a private practitioners are more worried about કે વેક્સિન આપીને કંઈ interception થઈ ગયું તો મારું નામ આવશે. And so there are studies also that what number, there is a mathematical model by which they have calculated that what number of deaths could be prevented by extending the rotavirus vaccine administration age, upper limit, and versus number of deaths caused due to interception because of extending the age. And when these figures were compared, there was a huge difference in these two figures. So to be very specific, you can prevent the, means when there is a restricted vaccination schedule, like your first dose should be by 15 weeks and the last dose should be by 8 months, the deaths due to acute GE will be 1,55,000 and death due to interception will be 253. But when there is an unrestricted schedule up to age of 3 years, the number of deaths due to acute GE 2,83,000 and number of deaths due to interception were 547. So particularly considering the underprivileged children who are still having poor sanitation and poor hygiene, so for protection of these children, the government of India has modified this recommendation and they have extended this vaccination age up to 1 year and beyond. But please remember, the private practitioners, when you are catering the individual child, we need to follow the ACVIP recommendations.
That is what. And as far
Yeah.
as that is concerned, they found that there is 85% efficacy. It improves, especially for the severe diarrhea, if we increase
the age. So in fact, there were studies that if instead of 6, 10, 14, if it is a 10, 14 and third dose, then there will be better immunogenicity. But again, you have to have a programmatic convenience also, that when you are calling the patient for 3 doses of penta, 3 doses of say pneumococcal, in that case, if the Rota is also administered same time, it will be having better, means less number of visits for the patient and better compliance. So in that context, again, though there may be little less seroconversion, but it is adequate to provide that protection to that child.
I want more point I wanted to
Yeah,
add was,
please be quick.
as far as interception is concerned, there are enough studies, post-marketing surveillance published by INCLEN also, and our own group, whatever studies we have
Yes.
done related to vaccine, and we did not find a relatively higher
Higher
risk.
incidence.
RR factor was less than 1. So it means they are safe vaccines even if we are giving it, and so we need not be very much
Okay.
worried about it.
So let us move to the meningococcal vaccines. So, Dr. Bhaskar, earlier we discussed about the vaccines which are available for India. Now, because meningococcal, again, it is not a popular vaccine in our country, and as of now, the ACI recommendations are also like that, that it is not for all children. It is for some special class of children. So when we talk about the vaccine, we should know about, because at times now we have a we are global doctors. We have patients coming from other countries also. So what are the different types of vaccines available globally, and then we can discuss about the dosage schedule also.
Sir, essentially there are two types of meningococcal
Yes.
vaccines. One is polysaccharide vaccines and another
Conjugate.
one is conjugate vaccines. Polysaccharide vaccines are no more in wide use in our country and not marketed also because of their poor numerical memory induction, and also there is no long-lasting immunity production, and also we cannot give them before 2 years of
2
age.
years of age.
And another one, variety is conjugate vaccines, and they are conjugated either with the diphtheria toxide or tetanus toxide. And the first one is monovalent A vaccine.
Yeah, that is specifically
Afrivac.
based manufactured for the African belt
Yes.
of
So
meningococcal belt, and
it's more
it
in,
is by serum, but it is not marketed in India.
Yes, sir. And even though it is pre-qualified, got license in the 2010 itself, but it's not being marketed by Serum Institute. Another one is monovalent C vaccine or monovalent B. That is more in US, and they are not available in India also, sir. And bivalent A and C. Right now we are having only quadrivalent ACYW vaccines. There are two types, Menactra and Menvac. Menactra is available in liquid form. Menvac is either A is in lyophilized powder form. We have to mix with the other three components.
Right. So
Now we are getting the pentavalent vaccine from the serum, which is already purchased by the Africa, because after using A, the disease incidence has come down.
Yes.
Now they are recommending to use that pentavalent vaccine. Maybe in future it will be available in India, sir.
So Tushar bhai, as I said, this is not vaccine for all.
So this is not routinely recommended by ACVIP for routine use in pediatrics, of course, but it is a vaccine for specific indication. We know that ACVIP recommendation is based on the science, but we also know that WHO also recommends in the same way that for if there is a moderate or high endemicity, like 2 to 10 or more than 10 cases per lakh of population per year, or there are many outbreaks, then it is recommended routinely. Whereas in our country, as based on the reportings that we have, based on the data that we have, ACVIP says that it is not a routine vaccine for routine use, but it is recommended for high risk individuals. So all those complement deficiency, asplenia, functional or anatomical, it is recommended for various other like CSF leaks and the chronic conditions, immunosuppressive drugs, congenital or acquired immunodeficiency. So this is one high risk situation. Others, it is recommended for travelers who are traveling, like say for international studies, who are going for further studies to US. It is also recommended for travelers to African belt, Hajj pilgrimage. So all those people, it is compulsory vaccine.
The Saudi government, it is compulsory to have the this
certificate,
MCV vaccination.
Along with this, yellow fever and oral polio, both are recommended for Hajj travelers, and also for laboratory and healthcare workers. It's used also in outbreak situation along with chemoprophylaxis, and so this is the typical use that one can think of.
Sir, one more indication should be added actually.
For?
Where there is overcrowding is there.
Overcrowding.
In hostels.
Overcrowding you will see have everywhere in India.
Hostels and military barricades.
So
hostels and military
barricades. That is the reason the Western institutes, they insist for our children getting the meningococcal vaccine. And many times when patient comes and tell me, कि sir एमनेम लख्या पोन है, तो पहलू तो वो एम कहूँ कि I never give any false certificate. At the same time, I explain them that, see why this recommendation is there. Because if your child develops infection there in a dormitory type of accommodations or a hostel accommodation, then in fact you will be in trouble and your child will be...
In our country also, like IITs do recommend that you take this vaccine and come, like the Western Institute.
Absolutely.
But not all the hostels.
Not all.
When I sent my daughter to hostel in Mumbai, I did give her a vaccine. So like, that's why it's good vaccine.
That is because almost 10% of adolescents are carriers of meningococcus. 10% of adolescents are carriers. Whenever their immunity goes down, whenever there is some epithelial barrier problem, the disease is likely to occur for the adolescents. So this vaccine can be recommended for overcrowding, but it is not there in the ACV.
Madam, quickly about recommendations for anatomical or a functional splenic patient. There are two products available. We are talking about now the conjugate vaccine only. We are not talking about the polysaccharide vaccine. So, what is the recommendations for this, the age groups as well as number of doses?
This is actually dependent on the age group, and we all know that Manectra can be given between 9 to 23 months.
Yes.
And it is not recommended. 24
months beyond.
and older, you give 2 doses at least 8 weeks apart. And as far as Menveo is concerned, then the dose 1 at 2 months of age. So you have to follow 4 dose series.
Total 4 dose schedule,
Yeah.
2, 4, 6 and 12.
Single dose.
So beyond
So-
2 years, it is 1 dose.
Yeah.
Typo-
Under 2 years, it is 2 doses.
Sir, no.
I think
One-
there
one-
is some typographical
one more-
error.
Yeah, maybe.
no.
But
I think.
But in short, see, please remember that Manectra
So when you are using
is
Manectra,
not
Sir,
licensed for using.
so Manectra is licensed for use from 9 months and onwards, whereas Menveo is licensed to use beyond 2 years. When you are using in
Okay,
at
maybe.
9 months, you give 2 dose schedule, and when you give beyond 2 years, it is 1 dose, whether you
Copy,
use
paste.
Manectra or Menveo. The
No, no,
second
this-
thing is that when you are using together this Manectra and Previnar, you
We
cannot
have to
do
give-
together, especially in
First,
this
Prevenar
mania
schedule has to
complement.
be completed.
Yeah, so you give Previnar first and then you give Manectra. But
Right.
if you use Menveo, then you can give together also.
One
Right.
clarification, sir has brought that schedule. Menveo is used for infants in US. In
Yes.
high risk children, for infants, Menveo is used. For India, because it is not, studies are not done below 2
In-
years, it is not permitted.
Not
to be
licensed as of now. Right. Last vaccine, Japanese encephalitis vaccine. Dr. Bhaskar sir, you are from the area where JE is endemic, from Telangana.
Yes.
Of course, there are many other states where there may be a higher prevalence than Telangana. But what is the current epidemiology? Because earlier we used to believe that this is not a vaccine for our country, Japanese encephalitis vaccine. But now there are enough data from National Vector-Borne Disease Control Program, and if you visit their website, they have the statistics, latest statistics, that more than 300 districts are having Japanese A activity. So, what is the government recommendation also regarding the vaccine? Because you are in your state, it must be administered in
Yes,
the
Angara it is.
government immunization schedule also.
That JE virus is a very important virus causing acute encephalitis. And acute encephalitis syndrome, 25% of cases are suspected to be caused by JV virus. And more than 23 countries spanning in West Pacific and South Asia and Asian countries are under the risk of JV virus. Coming to India, the burden is more than 300 districts are under the endemic zone, and including highly endemic states are West Bengal, Assam, Northern Uttar Pradesh, and
And
Andhra Pradesh, and
UP,
including our
Bihar.
Telangana Rangareddy district. And the once it was used to be a rural infection,
Yeah, but nowadays-
because of rapid urbanization of the rural areas also, and rearing practice of the pigs and paddy, and it is coming to the semi urban and peri-urbanate areas also. And another important epidemiological feature is it is infecting the adult population
also.
And every year for the last 2 decades, the geographical area under high risk is increasing every year, sir. And JV, under government of India
Government, yeah.
recommendations, it is to be given only in the declared endemic zones, including urban and rural areas, covering up to 1 to 15 years of age group, sir. And
Right.
if there is any high risk districts where the adults also identified as a high risk group, we can give above 15 years also. And Rangareddy district, one of the districts where adults are more than 20% of the total JE cases.
Right. So, Dr. Surendranath, you can take this about the vaccines which are available. So both the private sector vaccines as well as the public sector vaccine. Because in Gujarat, people may not be knowing about that there is a vaccine which is separate, different than the one which is marketed for the private sector. But the endemic districts or endemic areas, there is a separate vaccine which is no more available in the private sector, only by the government. And the schedule is again different. So, Dr. Surendranath, can you throw
So
some
we
light
have
on it?
two kinds of vaccines. One is the live attenuated, another is the inactivated vaccines. The live attenuated vaccine is manufactured by the Chinese, which is imported by the government. So it is also strain SA 14, 14, 12. The thing is that this vaccine in the government schedule is given along with the MMR vaccine at 9 months.
9 months.
Another dose between 15 to 18 months along with the DPT booster. This vaccine is given. The private market, we have two inactivated vaccines. One is for Bharat Biotech, another is from BE. The BE vaccine is same attenuated strain which is used for the live vaccine is formaldehyde inactivated, and it is given as a intramuscular injection at 1 year of age, and the second dose to be repeated after 1 month. This dose comes in a 2-dose schedule. I mean, in the infants less than 3 years, it is 3 micrograms, whereas adults it is 6 micrograms. So you have to identify and give it.
Sir, what about your experience with maybe even Dr. Bhaskar also or Sangeeta ma'am also can answer this. What about the child who is staying in an endemic region is offered a vaccine as per the government schedule? Now, is there any recommendations for the revaccination of that child, or how long this vaccine will give the protection to the
At
child?
present, there is no definite clear-cut indications for the booster, but some of the vaccinology textbooks say that a booster may be required after 1 or 2 years. But it is not the recommendation as far
But
as
for live attenuated, it is not required. It is not.
yeah,
Because actually, I had done the study,
So
studied.
that is why I wanted to bring this point.
And another thing, this live attenuated vaccine is right now not available in the government service.
5 minutes.
They are also using the inactivated vaccine.
So anyway, let us address this last query related to the JE, and then we will have a rapid fire, and maybe we may exceed by 1 or 2 minutes.
So
Please
as per ACVIP guidelines, the vaccine is also recommended for travelers. One needs to understand that if you are going to stay in the endemic belt for 4 weeks or more, or you are going to be in outdoors, or you are going to be in that rural area where the risk of exposure to JE mosquitoes are high, you should take the vaccine at least and finish the schedule at least 1 week before the date of travel.
So basically, again, it depends on which high endemic area you are traveling and high transmission season you are traveling, that is monsoon months, and what type of your traveling pattern is there. If you are hitchhiking, if you are camping, if you are going for say rural tours. Last year I went to Vietnam, so before going to Vietnam, all three of us had taken this Japanese encephalitis vaccine. So definitely, because this is a deadly disease and which can be 100% prevented by the vaccine. So with this, let us move on to the rapid fire, and I request the speakers, experts to be rapid in real sense so that મારે પ્રફુલ્લનો ઉપકાર લેવો ન પડે. So Tushar, first case scenario, Surendranath sir, first case scenario, a child was administered first dose of hepatitis A vaccine in January 2023 and was advised to come in the June after 6 months, but the child has now come in January 2024. Restart the schedule, give a single dose and of live attenuated vaccine, or complete the schedule as usual.
There is no need to restart the schedule. Give the second dose of vaccine, that will complete the schedule.
So the answer is very clear, and there is a one Argentinian study where more than 10,000 children, they were offered single dose of hepatitis A vaccine as a schedule, and in these children the incidence of hepatitis A for nearly 10 years they had followed up, and there was no no increase in the incidence of the hepatitis A in these children. So single dose is sufficient, but as of now ACVIP is recommending 2 doses, But if by chance patient has delayed, don't restart the schedule. Need of booster dose hepatitis A?
There is no need. I mean,
No
two
need.
doses.
When will you go for a screening in a older child?
Yeah, latest purple book of immunization.
But is it cost effective?
Yes, latest purple book of immunization says that after 10 years, do a screening test and give the vaccine. That this is from the latest purple.
Yeah, it is
after seeing your questions, I have gone through the ACVIP new book. It clearly says do a screening. I don't know whether it is cost effective or not, but the book is.
So see, it is recommended, but again, if you go by reality, no one does it. Because the screening may not be cost effective. Who should not receive hepatitis A vaccine?
I think live attenuated should not be given to the
Immunocompromised. Right. Role of hepatitis A in chronic, age. Naturally, that is the minimum age, eligibility age. And role of hepatitis in chronic liver disease.
Definitely we have to give, sir.
And hepatitis B carrier also. So there are studies that patients with hepatitis B and C, if they by chance develop hepatitis A infection, they will have a more severe course. So for that reason, definitely these are the candidates for the vaccination. Rapid fire to Tushar. Baby has just received a first dose of RVV and then she developed lab confirmed rotavirus. How will you proceed?
Complete the schedule as per recommendation.
Right. Why?
So there is no need to discontinue the schedule, or there is no need to accelerate the schedule. You know that even with 2 episodes, there are different strains and things. So your risk still remains, and you want to protect.
Absolutely. So firstly, in fact, many means again this may not be a real time scenario, because many we don't go for a rotavirus diagnosis in clinical practice. But by chance, if you have got it, the one infection is not going to give the full time lifetime protection. So you need, and as you said, the serotypes also are different. So will you administer rotavirus vaccine to child with history of
Interception, as Dr. Surendra sir was saying, the recent purple book puts this under contraindication, but we already discussed, and it can be considered as a precaution. So with precaution, one may consider, or it's an absolute contraindication, depending on how you take
and
it.
severe
For
combined
severe combined,
hepatitis
definitely
C
it's an
also
absolute
it is.
contraindication.
And what about child with HIV?
So a child with HIV who is asymptomatic or whose counts and other things are high, definitely you can give, you should give.
So again, the WHO also says that you have to decide the cost benefit ratio, and based on that, definitely it is recommended for, because this is having high mortality. Last question: accidentally first dose given 15 weeks 5 days age, what to do further?
Give second and third dose.
Okay. About preterm, I think we all know
so
that.
as per the chronological age,
Right.
you must give. There is
Right.
no reason to worry. So especially when the child is stable. So if child is in NICU, we may not give, because there is a risk of exposure to other preterm babies or other babies who are in the NICU.
Madam, we are going to skip this because it is already answered.
I was going to say that
Which
only.
are the children who are at risk of meningococcal disease? I think we have already enlisted it for the interest of the
this
time.
Answer is
Contact
both.
of cases,
For this, both.
both.
Yes.
Chemoprophylaxis?
Because I also took it.
Right. And because we know that see, the vaccine again will not be effective immediately. Plus, unless until you have that serotype prevalence, then and then only if there is a matching of the serotype with the prevalence and the vaccine, then you will be safe. So you need to provide both chemoprophylaxis as well as the vaccine.
We have had these outbreaks in Delhi, no? 85, 88 when I was a resident. So I have taken 85. 88,
Revaccination
91.
need? Any revaccination need?
Yes, there is need for revaccination, especially in the ones who are
Immunocompromised with the complement.
And there you have to give 2 doses, 8 to 12 weeks apart, and
Right.
booster every 5 years.
And of course,
if there is primary series given before 7 years, then you have to give a booster after 3 years, and all the lab workers, healthcare
so
workers.
those
the
who are
boosters
professionally at risk, they should definitely receive. And can
here I
we
want to say-
interchangeably use?
Yeah. They both
Because
can
all
be
these
used.
questions comes to us. રોટાની વાત આવે ત્યારે તો આપણે કહીએ કે ના આપો, કે કોઈ પણ બીજી વેક્સિનોમાં પેન્ટાની વાત આવે તો કહીએ કે આપણે આપો. So here the based on the age of the child, you have
अगर
to.
वो less than 9 months है तो Menectra देना है, और अगर more than that. Another thing which I wanted to add over here is Menectra is discontinued as per the this thing from
US.
October 23. They have continued the manufacturing in US.
Yeah.
So there might be a limited availability over here for Manectra. So it is the men quad fee. That is the Pfizer vaccine, which is the quadrivalent, which is going to come in. It is yet to come to India.
Bhaskar sir, about
So this is what I wanted for your
या मैडम
information.
वो
That is
अपन
all.
बाद में जो भी हो तो सी वी डोंट हैव एनी चॉइस, जो भी अवेलेबल है वही ऑर्डर कर सकते हैं. बट एनीवे, अबाउट द जेई वैक्सीन, देयर इज अ वन प्राइवेट मैन्युफैक्चरर हु सेज दैट one dose is sufficient, and our ACVIP
There
says
is one product, Immunization vaccine,
Hmm.
previously called as Chimorix JV vaccine. It is a very safe and very seroprotective and immunoprotective also. And its single dose is enough according to their clinical trials. Already they applied for registration. It is going to come into market soon.
but as of now
ACVIP says 2 doses.
Bharat Biotech, I'm talking about.
claims that 1 dose is enough, but
Yeah.
ACVIP recommends 2 doses.
So they said that they have a study that those who missed the second dose, even after they had missed the second dose, the incidence of Japanese encephalitis infection was not that high in their that cohort, and that's why they were recommending that 1 dose is sufficient. But I think SCVIP has clear-cut guidance about 2 doses. About
Yes, sir.
re-administration of the vaccine along with the other vaccines
It can be given, sir.
can be given, and
No
particularly as Dr.
Yes.
Surendranath sir had told about that in the government sector along with the MR vaccine. And about this, most of the JE vaccines are derived from G3 genotypes. So are these vaccines equally effective against all genotypes?
Yes, JE vaccines which are derived from G genotype, they act against effectively G1, G2, G3, G4, but not against G5.
G5.
And we are observing increased emergence of G5 genotype infections.
Okay. So I think a big round of applause for the experts, because they finish the discussion in time, and thank the organizers as well as my chairpersons. Thank you.